Hello everyone, this is Dr. Garima Sachdeva, and today we'll be discussing about the GTG Green Top guideline on sickle cell disease. Particularly, we will be discussing about the complications associated with sickle cell disease and how do we manage that.
Of blood transfusion in cases of sickle cell disease. So if the patient has previous serious medical, obstetric or fetal complications, then you give exchange or top-up transfusion. The women who are already on transfusion for primary or secondary stroke prevention or for prevention of severe disease complications, then it should be continued. In twin pregnancies also, you give these patients prophylactic transfusions. Acute anemia, again you have to give top-up transfusion, and acute chest syndrome or acute stroke, you have to give exchange transfusion. So if you understand that in sickle cell disease, all these problems, acute chest syndrome is basically when these sickled RBCs, they clog the vessels in the chest, causing chest pain, severe chest pain or pneumonia-like symptoms. So it is primarily because of those. So if you have to replace the blood which is causing those symptoms. Again, acute stroke. Usually if there is a stroke, you have to give thrombolysis, streptokinase and all you give. Hello, am I audible? Yeah. So if there is stroke, you usually give thrombolysis, but in sickle cell disease, you do not give thrombolysis. This is again a question. So sickle cell disease, all the problems are because of the defective RBCs in the blood. So you have to replace that. So that is a treatment. Okay. Am I clear so far? Yeah.
Yeah. And I have a doubt, like if patient is anemic, we are checking her like ferritin level, okay, initially during her booking itself. What if she is anemic? What do we do that time?
Then if iron deficiency is there, then you give iron. Otherwise, you give blood transfusion.
Okay.
Yeah. Because there is
So
no
everything is IV only.
Hmm?
Everything is IV only.
Yeah. Okay. So
And
coming
apart from this, do this on oral line?
apart from this,
Do we put them on oral line? Like how do we start from fourth month?
iron we give only if it's deficient. Otherwise, we don't give. If there is
So
iron
in antenatal case.
in antenatal cases only, I'm telling you, we give iron only if they're deficient. You check for the iron levels. If there is iron deficiency, you give. Otherwise, usually these patients, even this sickle cell as well as thalassemia, both of these patients, because it's a hemolytic anemia. So when the RBCs will break down, what will be released in the circulation? It will be broken hemoglobin and the iron. So usually these patients have higher iron. They have iron overload, which is causing problem. So if you load them more with
Yeah,
iron, it
yeah.
will cause more problem.
Okay, 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 ma'am. Okay, got it.
Yeah. So management of acute painful crisis. So it is one of the most common complications occurring with sickle cell disease, seen in 27 to 50% cases. You have to manage them. You have to involve the multidisciplinary team, which will include obstetricians, midwives, hematologists, anesthetists. You have to assess them for any infection, and in case it is there, you have to give them antibiotics, fluid and oxygen, and thromboprophylaxis that has to be given, assessed and given. Like once the patient is admitted, you have to give them thromboprophylaxis. Okay. Then for management of pain, you have to ask them to avoid the precipitants like cold environment, excessive exercise, dehydration and stress. And the WHO has given an analgesic ladder. So you go stepwise how to manage the pain. If there is mild pain, you give paracetamol. You can give NSAIDs between 12 to 28 weeks of gestation. Then if there is moderate pain, then you give them weak opioids like codidramol or codamol or dihydrocodeine. Then if there is severe pain, you give them stronger opioids. And one thing which should not be given in cases of sickle cell disease is pethidine. Okay, it should be avoided because it can increase the risk of seizures in patients with sickle cell disease? Again, a question, recall question. Pethidine should not be given. So pethidine is usually used as a this will be asked in various modules. So it is one of the labor analgesia which is used. So there are multiple options like to control the labor pains. Okay. So you can give epidural, you can give pethidine, okay, you can offer them water birth. So they ask you like what should be avoided as a labor analgesia in sickle cell disease. So pethidine should not be used, okay, because it increases the risk of seizures. Uh, it's again an exam tested question. So this is how you manage the acute pain. If the you'll do a clinical assessment. If the pain is severe and oral analgesics are not effective, then you give them strong opioids like morphine. Also, you give adjuvant non-opioid analgesia like paracetamol and NSAIDs if she's between 12 to 28 weeks. You give them with like when once you're giving opioids what they cause itching, they cause constipation, they cause vomiting. So in order to avoid the side effects, you give them laxatives, antipruritic, antiemetics if required. So this is to counteract the side effects of opioids. Then you monitor the pain, the sedation level. Morphine also causes, these opioids cause sedation. You monitor the vital signs, you monitor the respiratory rate, oxygen saturation every 20 to 30 minutes until the pain is controlled and signs are stable. Then you monitor them 2 hourly and hourly if you are still giving them parenteral opiates. Then once the patients settle, you give them, in order to avoid further pain episodes, you give them rescue doses of analgesia. If the respiratory rate becomes less than 10 per minute, you omit the maintenance analgesia and consider naloxone. So basically, if there is strong respiratory depression, okay, am I clear so far?
Okay.
Yeah. So if
Yes,
the
ma'am.
with this morphine, so along with these side effects like constipation, itching, and vomiting, there can be respiratory depression also. So if the respiratory rate goes very low, it is less than 10, then you have to give an opioid antagonist, the antidote for morphine. So that is naloxone. Again, this is an exam tested
Okay.
question. So they can give you a scenario:
Ma'am,
patient with acute chest syndrome being treated with severe pain, treated with morphine, respiratory rate is 8 or 9, the patient is having breathing difficulty. What will you do? You'll give what?
naloxone is the antidote of opioid.
Yes, you will give naloxone there. Okay. Then you consider analgesia after 2 to 3 days. Is consider reducing analgesia after 2 to 3 days and replacing injections with equivalent doses of oral analgesia, and discharge a patient once the pain is controlled, and arrange any necessary home care and outpatient follow up if required. Okay, understood. This is
Okay.
clear so far. Then
Yes, ma'am.
coming over to the next complication, acute chest syndrome. So it is the second most common complication after acute pain syndrome, seen in 7 to 20% of the cases, and it has symptoms like pneumonia or H1N1. So there are respiratory symptoms like tachypnea, chest pain, cough, shortness of breath in the presence of new infiltrates on the chest X-ray. And how do you manage acute chest syndrome? How do you manage acute chest syndrome?
Acute chest.
How do you manage? How do you manage acute
Yes,
stroke?
ma'am. We give. You're asking for the investigative part.
No, no. How do you manage? Like if a patient complain, known case of sickle cell disease comes to you with severe chest pain and all these symptoms, the respiratory rate is 24,
Uh,
25, she's cough, she's shortness of breath.
we give
How, hmm?
penicillin. We give penicillin.
Yes, you will give them antibiotics. And why this problem is occurring? Why this acute chest syndrome or acute stroke, why are they occurring? They're because of the RBC's breakdown, clogging the vessel. So you have to replace the blood. You give them blood transfusions. So treatment is IV antibiotics, give oxygen and blood transfusion. Okay, so you give them top up blood transfusion if the hemoglobin is falling, or if the hemoglobin is less than 6.5, and exchange transfusion if there is severe hypoxia and if the hemoglobin level is maintained. Then about pulmonary embolism, this is again a risk factor. So you give them low molecular weight heparin should be commenced until the woman has been reviewed by the senior staff and definitive investigations have been undertaken. So any patient of sickle cell disease who is admitted, you have to give them low molecular weight heparin. Then acute stroke. So for acute stroke, both infarctive as well as hemorrhagic can occur. You have to get a neurological opinion. It is a medical emergency, and you give them rapid exchange blood transfusion and arrange for a blood imaging. Thrombolysis is not indicated. Again, repeatedly asked question, how do you manage a case of acute stroke? You give exchange transfusion. You do not give thrombolysis. Okay. Then management of acute anemia. So acute anemia in sickle cell disease can occur because of erythrovirus infection, which causes a red cell maturation arrest and an aplastic crisis, which is characterized by reticulocytopenia. Low retic count in acute anemia in sickle cell disease indicate erythrovirus infection. So you have to check a retic count if the anemia, if there is hemoglobin is very low, and you treat them with blood transfusion. And this erythrovirus, it can be transmitted, so you have to isolate them. And there is also a risk of vertical transmission to the baby, which can result in hydrops fetalis, so you have to get a fetal medicine specialist review in this case. Okay. Then other causes of acute anemia, if there is bleeding or any other cause of anemia incidental to sickle cell disease, or if there is incidental malaria or splenic sequestration in women with a mild phenotype. Then this was about antenatal care. And then how do you plan for delivery? Like during how do you plan for the delivery? What should be the time and mode of delivery? So you can go for delivery after 38 weeks. You plan after 38 weeks, and it is not a contraindication to vaginal delivery. And cesarean section only for obstetric indication should be done. Then you have to, because the patient might bleed, so you have to arrange the blood for the patient. If the patient has atypical antibodies, you have to keep the blood cross matched and ready. If there are no atypical antibodies, you can just group it and save it. In case patient has hip replacements because of avascular necrosis, then you have to discuss about the positions of delivery. Then she might not be able to get into lithotomy position. And this is an high risk pregnancy, and it has to be managed in consultant led unit in the hospital.
Okay.
And women should be kept warm and adequately hydrated. You have to do a continuous intrapartum fetal monitoring. CTG should be done. Analgesia during labor, you have to get an anesthetic assessment, and pethidine should be avoided because it can cause seizures. If you want to give, you can give opiates for pain relief. Regional anesthesia like epidural can be given. Okay. Or spinal for cesarean. Then about the postpartum care, if the baby is at high risk of sickle cell disease, then you have to test the baby as well. If the partner was not tested, or if like the patient has not gone for any invasive testing like CVS or something, then you have to check for the baby. Then you should maintain the maternal oxygen saturation above 94%, adequate hydration. You have to give low molecular weight heparin. Again, this is a question. For how long post delivery do you give low molecular weight heparin? So if it's a vaginal delivery, you give it for 7 days. And if it's a cesarean section, you give it for 6 weeks postpartum. Okay, so antenatal, if there are additional risk factors, then you will give low molecular weight heparin. Postnatally, after delivery, for everybody, you will give low molecular weight heparin, which will depend. If it's a normal delivery, you give it for 7 days. If it's a cesarean, you give it for 6 weeks. Okay.
Okay. Okay.
Okay. Then contraception. So
And
first,
why
sorry,
are we continuing until 6 weeks? Why are we continuing until 6 weeks if in
because there
case of
is very high risk
cesarean?
of because there is very high risk of cesarean, the patient will not be that much ambulatory. No, it's again a risk factor. Okay,
Okay,
so
okay, yeah. Prolong.
sickle cell is
Okay,
a thromboembolic, like pregnancy. It's again a thrombo high. There are higher risk of thromboembolism, and again, cesarean will increase the risk, and
okay,
sickle cell disease again increases the risk. So you have to give it. Then about the contraception
okay,
post pregnancy, the first line will be progesterone only contraceptives. Second line will be estrogen containing. Okay.
Hope this video was useful about the complications of sickle cell disease in pregnancy and the management. So if you like the video, please do subscribe to the channel. Thank you so much for your time.